Good evening, sir. Shall I start?
Hi. Yes, Pranav, please start. I'm sorry, my other phone was dead, so
Yes, sir.
go
So,
ahead.
in
Yeah.
today's class on Holiday EKR report, we are going to cover the refractive index of cornea, refractive index of the cornea for IOL power calculations, and how it relates to latest keratometries, the Holiday report, Holiday EKR 65 report, examples of that, and the IOL Master 700 true K or total K values. So what is the refractive index of cornea? So according to the layers of cornea, it varies from 1.4 at the epithelium, 1.38 at the Bowman's, 1.369 in the midstroma, 1.37 at the endothelium, 1.337 in the tear film aqueous layer, 1.48 over the lipid layer. So overall, the tear film cornea complex has a refractive error of somewhere around 1.42 to 1.43, and the refractive index of aqueous humor is around 1.336 or 1.34. So on an average, the universally accepted refractive index of cornea is 1.376. But the refractive index used for IOL power calculations is 1.3375. So where does this 1.3375 come in? So here we see n dash minus n upon r, which is the Snell's law of refraction. N dash being where the ray is going, n where the ray is coming from, and r is the radius of curvature. According to the AAO, the anterior surface of cornea has a power of plus 48 diopters, and the posterior surface of cornea has a power of minus 6 diopters. Hence, the cornea has an overall power of plus 42 diopters. Uh, so the power of the cornea is calculated using the radius of curvature of the anterior cornea as well as the posterior cornea by filling in the relevant refractive indices, that is of the cornea, air, and aqueous humor. So where did the 1.3375 come from? So essentially, determination of the posterior corneal curvature has been a difficult task. Until recently, we didn't have all these Scheimpflug imaging and slit scanning techniques. So determination of the posterior corneal curvature was a very difficult task. Hence, it was decided that a single refractive index was planned to be used for the cornea. So retrospectively, what they did is uh, they decided that a 7.5 mm radius of curvature should have a 45 diopter power, and on the basis of that they calculated the refractive index of cornea, which then came out to be 1.3375. To complicate matters, 1.3375 has been found to overestimate the true corneal power by at least half a diopter. Hence, most formulae use refractive index of 1.33 nowadays. So this 1.33, if we put it in the same formula, the power of the cornea comes out to be 44.4 diopters. So 1.3375 is the modified refractive index of the cornea, as we were not able to calculate the posterior curvature of cornea. It assumes that there is a fixed relationship between the anterior and posterior corneal curvatures, and the ratio is 82.2% or 0.822. Because of the advent of various laser vision correction procedures, this ratio no longer stays valid. And if we were to use the refractive index of 1.3375 to calculate IOL powers, it can go horribly wrong in most cases. So what were the keratometers that were available to us? This is a manual keratometer, which is most commonly used. This is a Bosch and Lomb keratometer, in which four paracentral points, which are 3 mm apart, are projected, and it assumes a fixed relationship between the paracentral and central cornea, and the paracentral readings are extrapolated for the central cornea. It works on the principle of doubling. These are the topographers, which are Placido disc based, and recent ones being tomography devices, which work on two principles, which is the scanning slit and Scheimpflug imaging. In both of these, we are able to get the posterior corneal curvature. So in tomography, direct estimation of the central corneal curvature, both anterior and posterior, as well as corneal thickness is available. So the advantage is that we get accurate K values for IOL power calculation, and it does not rely on assumptions of 1.3375 or the 82.2% ratio. So in our pentacam, we have lots and lots of corneal
So
power maps.
Pranav, I want to ask you,
Yes, sir.
Pranav, can you hear me?
Yes, sir. Yes, sir.
Okay, I wanted to ask you here that Scheinflug has been around for 15 years, and of course it works great like you've shown. Do you think OCT, AS-OCT derived corneal powers and keratometries are more accurate than even Scheinflug, or they are less accurate?
Sir, I'm not sure about the new Swepsost OCT technology versus Scheimpflug imaging values, sir.
It'll be interesting because apparently the resolution of the OCT is way ahead of Scheinflug. And apparently the corneal powers derived from OCT might be way superior than Scheinflug, which we are currently using. So it remains to be seen that whether that will eventually take the lead. But I just wanted to just kind of here point out that OCT is now likely to be the future, because even Oculus, which makes a pentacam, is likely to launch this either this year in the academy or something, their own OCT and AS OCT based device which will replace the pentacam.
Okay, sir. Okay.
So let's go. Even their current biometry device, which is the AXL Wave, is an optical biometer where they are likely to have all these measurements derived finally from the keratometry. I mean, from the OCT, AS OCT. All the same, right now, what is available as the best option for us is what you're talking about. So let's stay on track.
Yes, sir. So there are various corneal power maps which are available to us on the pentacam. The first one being the axial or the sagittal curvature of the front cornea, and the one being the tangential curvature. Both of them measure the anterior surface and they use laws of Gaussian optics. The third map is the refractive power of the front cornea. It measures the anterior surface and uses Snell's law. So with all the three of these, they are not considering the posterior cornea at all. In the true net power map, the anterior and the posterior axial corneal curvatures are used to find a true net power. The flip side to that is it can't be used with a formula which considers the refractive index of 1.3375. A total corneal refractive power is a similar map, but it is based on ray tracing. It is similar that it considers both anterior and posterior corneal curvatures, and it is an arithmetic addition of that. But this map as well we cannot use with a formula which considers the refractive index of 1.3375. And coming to equivalent K reading 65 power, it uses Snell's law and it can be used with any formula that uses 1.3375 as the refractive index. So what is the equivalent K reading 65? So if we assume that the average anterior cornea is plus 48 diopters and an average posterior cornea is minus 6.8 diopters, on the pentacam, if we get an average posterior K as minus 6.5 diopters, that is, the posterior cornea in that case is minus 0.3 diopters lower than the average. Hence, to compensate for that, we will add plus 0.3 diopters to the anterior K. That is, an equivalent K reading of plus 48.3 diopters is gotten. What is the purpose of doing this? The purpose is to bring back the ratio closer to 82.2%, which is seen in normal corneas. What is the significance of the 65 in this? The 65 in this means that it is the weighted mean where 65% of the values are represented using the smallest range of points. So how do we get the equivalent K reading? Using Snell's law, we measure the anterior and the posterior power maps. Adjustment is done to the anterior K as mentioned before. And the purpose of this adjustment is to make the EKR values resemble closely with the SIMK anterior values. So these are a few overlays that we need to know for the maps, which I'm going to tell you later. The black and white dashed perimeter denotes the pupil margin. The black and white plus sign denotes the pupil center. The black brackets indicate the limbal center. The white circle with a black dot indicate the corneal vertex or the visual axis, and the small black circle indicate minimum pachymetry point. So coming to the Holladay report, in the Holladay report, we have a lot of tables and a lot of graphs. So the upper left corner shows all the biographic data, demographic data of the patient. In the upper middle panel, we can see that there is EKR 65 flat K1, EKR 65 steep K2, the mean EKR, and the astigmatism. This is by default done in a 4.5 mm zone. The total spherical aberration is also mentioned over here for deciding the IOL asphericity. The Q value or the asphericity coefficient is also mentioned over here. This ratio of the back is to front. If it is a post LASIK eye or a post laser vision correction eye, this value is going to be different. Here, this is a pre-op scan. The value is close to 82.2%. The most important thing that we need to know here is that they also give us the higher order aberrations of the wavefront, which we can mention as microns, and if it is more than 0.66 microns, it is denoted in yellow, and if it is more than 1 micron, it is denoted in red. In such patients, we can use multifocal IOLs, but carefully. In the upper right panel, here we have the pupil diameter, the horizontal white to white, the pachymetry minimum. Pachymetry minimum is usually temporal and inferior. If it is more than 0.61 mm inferior, it shows up as yellow and it gives us a suspicion of keratoconus. Another important and novel reading that they give on the Holladay report is the estimated pre-refractive mean K. This value can be used in the Aramberry double K method of IOL calculation post laser vision correction. It also denotes the refractive change which can possibly would have occurred after the laser vision correction. Another thing that it mentions is the external anterior chamber depth, which is the value which is used by most IOL calculation formulae. It also mentions the chord mu. Chord mu is nothing but the difference between the visual axis and the pupillary axis. In other terms, it is also known as angle kappa. So if a chord mu value of more than 0.42 is seen, it is shown in yellow. And if we use multifocal IOLs in such patients, we should be wary of glares and halos. So coming to the maps, this is the front curvature of the cornea. This is the tangential curvature of the corneal thickness, relative pachymetry, the front elevation, and the back elevation. So in the tangential map, one important thing to note is that the tangential curvature is based on the radius of curvature relative to the surface at that point. So for example, if the radius of curvature of Earth is said to be 4,000 miles on an average, and if we have a mountain of 6 miles, the radius of curvature is 4,006 miles, which 4,000 versus 4,006, there is very little difference in that. But in tangential curvature, it will show up as 6 miles, which is a significant difference. So tangential maps are more sensitive, and hence tangential maps in the Holladay EKR are always graded from 1 diopter steps as opposed to an axial map, which is less sensitive. So it needs a 0.5 diopter steps. So another thing to note in the front elevation and the back elevation maps, it uses a best fit toric ellipsoid with fixed asphericity. The front Q value is fixed at minus 0.22 and the back Q value is fixed at minus 0.20. Coming to the Holladay EKR 65 report page, in the upper part, we have all the demographic data. In this table, we have the EKR values at various pupil sizes. So what we see here is 1, 2, 3, and up to 7 mm. These are all the pupil sizes and not the distance from the corneal vertex. That is an important point to note. All the values are calculated from the pupil center so that only actual rays contributing to the retinal image are used. So in this we have flat K1, steep K2, EKR 65 mean and the astigmatism of EKR 65. It also gives us a zonal global mean EKR, zonal standard deviation and zonal sample. So let me just explain what it means. So we are considering EKR 65. 65 means we are considering 65% of the values in that area. So in 4.5 mm, the EKR 65 mean is 43.98 diopters, which means that the 65% of the values in 4.5 mm, their mean is 43.98 diopters. The zonal global mean EKR includes all 100% of the values in the 4.5 mm zone, and the zonal global mean EKR is 43.91. This is a box which gives us a graph. The blue line indicates the mean zonal EKR versus the zone diameter. This blue line, this is the important graph that we need to note. As we move towards the periphery, it should rise. In the lower left graph, this is a histogram. Histogram shows the relative frequency of the EKR power over a selected zone. So here we can see that we have selected a 4.5 mm zone. In this image, we can see that the dashed line is the pupil size and the red circle indicates the 4.5 mm zone. So this histogram is nothing but the EKR value distribution in the 4.5 mm zone. So if we were to see here, we have three values over here. One is 43.5, the other is 44, and the third one is 43.9. So let us go through what it means. So 43.9, if you see, the range of values is the 100% values. It includes all the values to give us a 43.9 value, which means that the global mean, that is 100% of the values in the 4.5 mm zone, give us a mean K of 43.91. Similarly, if we see that the highest peak is 43.5, this value corresponds to 43.5, which is given over here. Now let us have a look at this 44, which is denoted by these brackets, which include only the 65% of the values. So this is the EKR 65 mean, which is 43.98 or 44 diopters. So this is how we read the histogram. In this central part, we have a table which again gives us the flat K1, steep K2 with the axis, the mean EKR, the astigmatism, and other values. One thing important to note here is that the EKR 65 mean, global mean EKR, and the highest peak EKR in normal corneas, they vary by less than 0.5 diopters. So here it is a normal cornea and it varies less than 0.5 diopters. This is a EKR 65 power map in which EKR is used both in front as well as back cornea, and we apply Snell's law to get the equivalent 65K reading. It can be directly used in IOL power calculations. So the main point to note here is that EKR 65 values can be directly used in IOL power calculations, and no additional adjustment needs to be made for the back surface power since they are already included. So coming to an example, this is a patient who has undergone smile in the right eye. So if we were to just go through the data, we can see that the flat K1 and flat K2 are not that far apart, and the astigmatism of the EKR is very minimal. The back is to front radius ratio is 75%, which indicates that there has been some laser vision correction which has been done. And as expected, after smile surgery, the higher order aberrations have increased to an extent. The estimated pre-refractive keratometry mean was 44.4 diopters, and the estimated refractive change was somewhere around minus 3.8 diopters. This particular patient underwent a correction of around 4 diopters. I have gone through various
The actual
reports of. Yes, sir.
actual correction was for.
Yes, sir. But sir, that is what I was saying, sir. I went through multiple reports, and it is highly unreliable. This estimated
Mm,
pre-refractive mean K and this refractive change, absolutely, I mean, it varies sometimes by 2, 3 diopters. So it is not at all
mm.
reliable.
It's actually very difficult to imagine. And also, see, when EKR 65 was made, probably Smile did not exist. So it maybe it is more kind of you know kind of tuned to LASIK. I'm not sure. You'll have to just find out whether they did this for LASIK patients or it can be used on any refractive surgery, for example, RK or LASIK or Smile, because the three work a little differently. So it'll be
Yes,
worth
sir.
checking out how it falls out.
Yes, sir. So coming to the Holiday EKR 65 report in this patient, we can see that the axis of the flat K1 varies by about 10 degrees in the 4, 4.5 and 5 mm zone, and the flat axis also varies by around 10 to 15 degrees. The mean astigmatism is minimal. Here the blue graph shows a downward spike and then increase later on in the periphery, which means that there is flattening in the center, and as we go towards the periphery, it again steepens. So one thing I want you to note over here is this histogram in which the K values are almost identical. This is one way we can find out whether a refractive correction has been done properly or not, wherein the peak K, the mean K, and the global K, all of them resemble each other. So this is an example of a good correction. In this example, we can see a patient of keratoconus. So I want you to just see the histogram here. The histogram shows huge variation of the values from somewhere around 40 diopters to around 57 diopters. In such cases, the EKR 65 becomes more important because we don't know which K value to use, because if we look at this map, it looks like it is a bifocal cornea. So if the person wants to read, he is going to read from the steeper part, and if the patient wants to see at distance, he is going to see from this blue part. So keratoconic eyes are known to have bifocal tendencies, which has been shown over here by this dual peak in this map and huge variation in the distribution of the K values. So in such patients, if we look at the K values, which are the EKR 65 values, we see that from around 3 mm to 4 mm to 5 mm, there is very little variation in the axis as well as corneal power. And the mean astigmatism also remains fairly stable across the pupillary values. So this is one big advantage that we have of the EKR 65 values, where we don't know which K value to take for keratoconus patients. Another interesting thing is that this patient has undergone topo guided PRK followed by a CXL. After that, we can see that the histogram has drastically changed, in which the huge discrepancy in the distribution of values has reduced to a large extent. Also, the corneal surface has regularized to an extent. Similarly, we can see that the EKR 65 mean, the global mean EKR and the peak EKR vary less than around 1 diopters, which is a good sign. Previously, before treatment, the mean EKR was 43.3. The global EKR was 46 and the highest peak was 39, which means that it varied by around 3 to 4 diopters. After the treatment, we can see that it's varying by around only 1 diopter. So that is how it can help us analyze the effectiveness of treatment in keratoconus patients. This is a map of a patient preoperatively who has undergone LASIK. Let us just look at the histogram first and see the distribution of the values. It is very close knit. After the treatment, the values of the histogram are dispersed a bit. This is classical in cases where a LASIK or a laser vision correction has been done. So in patients who are normal, there is around 3 diopter range of values is seen. After LASIK, we see on the histogram around 5 diopter range, and after RK, usually 10 to 13 diopter range of values is seen. So in IOL power calculations of abnormal cornea, we should make it a point to use the EKR mean 65, especially in cases of post-refractive surgery, post-keratoplasty, keratoconus scar, and irregular astigmatism. Recently, we saw a patient who has undergone radial keratotomy in both the eyes, and we were supposed to operate her left eye. In the left eye, to complicate matters, she had a corneal patch graft. So in the right eye, if we see over here, the distribution of values is very huge. The variation between the values is decent enough. If we look at the axis and the K values, they are fairly uniform in the right eye over 4, 4.5 and 5 mm zone. Compare it with the left eye, which has a corneal patch graft. The red area which is seen over here is actually the area which the device has picked up as the 4.5 mm central zone. If you see the dashed lines shown here indicate that the pupil was considered to be like this because it was centered fallaciously on the patch graft. Hence, the values are like 51, 56, and it gave us a very wrong value because it was centered on the corneal patch graft. One way to rectify this mistake was to consider the total corneal power map. Although we might not consider the total corneal power maps and their values directly to be input into the IOL power calculation formulae, just the distribution and the regularity of the cornea in this central 4.5 mm zone can be found out by using this map. So
How did
coming
this
to,
patient do today post-op?
sir, she was doing good, sir. I mean, I recall her vision being one line better than what it was.
Okay, so I think gradually she'll improve. In fact, it was a very challenging case because in the area of the patch graft, the visibility behind the cornea was very poor, and obviously, patient was wanting to do a femto-assisted surgery. So the rexis was completed in the RK wala portions, and where also there was need to complete the rexis. And in the area behind the opacity, I had to just fashion a rexis with very little visualization. But I'm hoping that it will, come out somewhat better. But did you also, I mean, we also got very like crazy ILPAR calculations because the anterior was taking the K reading. That's why I was wanting to ask you, for example, the anterior being OCT derived keratometries was giving us Ks of 50s, whereas the pentacam was giving us Ks of 30s. So what a huge variation. And the anterior was giving us ILPARs of -8, whereas this was giving us +8. So
Yes, sir.
it'll be worth seeing what actually comes out more accurate, right?
Yes, sir.
Okay, let's go ahead.
So coming to
Sorry, I
studies.
have a question here.
Yes, ma'am.
Uh, Hello, yes. So in the previous case, initially the first scan that you showed was not centered on the pupil. You said now the pupil was being detected towards the patch graft side.
Yes,
Yes,
ma'am.
this one. And then in the next scan, it shows a little more central. So how did that happen?
Ma'am, these are two different maps. This is the EKR 65 map, and this is the
Hmm.
total corneal power map. So the EKR
Okay, okay.
65 maps, they are centered on the pupil, whereas
On
the
the
total
pupil. Hmm.
corneal power maps are centered on the corneal vertex. So that
Okay,
is
so
why
that
the
is how you could actually differentiate between the two parts on this map and not exactly on that one.
yes, ma'am. And also one important thing to note is that on EKR 65 map, we don't have an
Mm-hmm.
option to recalibrate or shift this red circle
Yes,
to an area where
yes.
we desire. Whereas in the
Hmm.
total corneal power map, we have this option in the edit calculation zone, wherein we can actually increase or decrease the size of this zone and also decenter it wherever we want.
But in the previous map itself, also you have a edit calculation zone, but I think you can't shift. How much can you shift with the edit calculation zone in
Ma'am,
this one?
they are only shifting the calculation zone, as in we can reduce the diameter or increase the diameter, but we cannot
Okay, not
displace the
exactly push
area.
it up. Okay,
In
okay,
the total corneal
right.
power map, we can actually displace the area as well and also modify the zone
Mhm.
diameter.
Okay. But again, did this not become like a bifocal cornea while you calculated this? Like as you mentioned in the other cases as well for the
Yes,
keratoconus
ma'am.
cases. So did this not become like a bifocal cornea again
Yes, ma'am. It is
when you
very
try to shift
flat
the
over
pupil to the
here and
center?
steep over here.
Mm-hmm. Hmm. Okay, okay. Yes.
Uh, in a pilot study conducted by Holladay et al., this was the first study that they have published regarding this, uh, regarding the EKR 65 maps. They have considered 100 eyes with prior hyperopic or myopic LASIK that did not have cataract surgery, and a test group of patients of 41 eyes with prior RK who underwent eventually cataract surgery. Pre and post LASIK pentacam were taken at 3 months, and the historical method was used to compute the theoretical postoperative K and then compared to the measured equivalent K reading from the pentacam. So in the test group of RKIs, the post-op refraction and the EKR were measured 3 months after cataract surgery, and the Holladay IOL consultant program was used to back calculate the theoretical K reading. And then the EKR measurements were then compared to the back calculated corneal power, and their conclusion was that when the historical data was not available, the EKR 65 of 4.5 mm performs well in post refractive surgery eyes. So this is the first study that they have published on the usefulness of the EKR values. Another study conducted by Omar et al. In this, they have compared the accuracy of Scheimpflug Holladay equivalent K readings after corneal refractive surgery in the absence of clinical history. So, in this, 18 patients underwent cataract surgery after refractive surgery, and the Pentacam 4.5 and 3 mm EKR were combined. I mean, the K values were used with an SRK2, SRKT of a Q, Holladay 1 and 2 formulae. So they have said that the smallest deviation from the predicted value was achieved by combining the 4.5 EKR with a Holladay 2 formula. So across studies, they have found out that the 4.5 mm zone of the EKR gives best values. Another study conducted by Saglick et al. It compared the comparison of Holladay equivalent K readings and anterior corneal surface keratometry measurements in keratoconus. So the purpose of the study was to compare the accuracy of anterior corneal SIM-K and EKR provided by the Pentacam, and it also compared it with the normal K provided by a Placido disc system using the T-cone topo in keratoconus and control eyes. They did not find a statistically significant difference between any keratometric values in the control group. However, a control group meaning there was no keratoconus in them. However, they found a statistically significant difference between the placebo K values, the Scheimpflug 3 mm, 4.5 mm, and SIMK values in the keratoconus group. So what they have said in their study is that placebo K, sir, the link is about to expire. I am sharing another link.
Okay.
I've shared the link, sir. Till then, I'll continue on this one, sir. So in their study, they have mentioned that the placebo Ks and the Scheimpflug SIM-K may increase the error margin in the keratoconus group, and in diseases which affect the posterior corneal surface, such as keratoconus. So according to the authors, in diseases which affect the posterior corneal surface, such as keratoconus, as the corneal evaluation zone increases, the margin of error of the systems which essentially evaluate the anterior corneal surface less than 3 mm, which means that the Placido and the topographers, the errors of those instruments could increase due to the asymmetrical placement of the corneal apex. And in their study, the results strongly prove that the Placido topography systems and other anterior surface measurements may cause inaccurate keratometry power and IOL calculations in posterior corneal diseases. Another study was conducted in untreated corneas. So the aim of the study was to compare the accuracy of pentacam Holladay EKR readings with the IOL master 500 keratometry in calculating IOL power in normal eyes having cataract surgery. So they found that there was a statistically significant difference between the mean K values of IOL master, pentacam EKR 3 and 4.5 mm, but they found that there was no statistically significant difference between the mean absolute refraction error of the IOL master and the EKR 3 and 4.5 mm for either Holladay 2 formula or the SRK2 formula. So essentially what they mean is that although the K values were differing significantly, in the end, the mean absolute refractive error after the surgery did not differ significantly. However, the most important point to note in this study is that the mean absolute refraction error for the Holladay 2 and the SRKT was lowest for the IOL Master 500, followed by EKR 4.5 mm. So, case can be made that in virgin corneas or untreated corneas, IOL Master or a anterior SIMK values still perform better than the EKR 4.5 mm values. Another study conducted by Saglick et al., in which they have analyzed Scheimpflug Holladay EKR values following CXL. So the aim of the study was to compare Holladay equivalent K readings and the anterior SIM-K values in keratoconus cases following corneal CXL. So they have studied 42 eyes of 30 patients with progressive keratoconus, and the results of their study showed that the Holladay EKR measurements differed from the SIMK measurements, especially in cases of mild keratoconus. And in addition to anterior corneal surface measurements, methods that can evaluate anterior and posterior surface curves could provide more accurate results in progression analysis. So there is a role of EKR values in finding out the progression of keratoconus post CXL as well. So that was the part on Holladay EKR 65, sir. I have a few slides on the IOL Master TK also.
Sure.
So IOL Master 700 has a 3-zone telecentric keratometry, essentially, which means that there are 18 points with 3 zones, I mean 3 zone diameters of 1.5, 2.5 and 3.5 mm, and an average of all 18 points is used. It has 3-zone consistency, which gives you improved repeatability and reproducibility, and 3-zone correlation. So the total keratometry measurement, what is the principle? In the IOL Master 700, we get the telecentric 3-zone keratometry with swept source OCT B scans. So a toric model is generated with posterior 3D points and a posterior torus fit is made, which is calibrated and which gives you posterior corneal values. And these posterior corneal values can be used in the TK formula. So essentially the IOL Master 700 is giving us the telecentric keratometry, which gives you the anterior corneal surface. The swept source OCT gives you the posterior corneal surface. This is the TK value that we get, and this TK value we can use in all the normal formulae as well as inbuilt formulae, which have been devised by Dr. Barrett and are inbuilt into the IOL Master 700, which are the Barrett TK Universal 2, Barrett TK Toric, and Barrett TrueK with TK. So when do we use TK values? So what are TK values? TK values are the same as EKR values. The funda is same in all of them. It essentially compensates for the change in the posterior corneal curvature from the normal. So similar example is that if the anterior corneal curvature is 48 diopters on an average and the posterior corneal curvature is -6 diopters on an average, let us assume that the posterior corneal curvature in some patient comes out to be -7 diopters. So it is higher than -1 diopters. So what TK does is essentially it converts the 48 -1 into 47 to compensate for that increase in negativity of the posterior corneal surface. The adjustment in the EKR 65 values and the TK values is the same. All of this is being done so that these values can be used with IOL power calculation formulae, which use the refractive index of 1.3375. So when do we use TK values? TK values can be used to decide about toric and non-toric IOL, and studies have shown that there is a strong agreement between the conventional K and the TK or the total K or the true K for the toric and non-toric IOL calculation, with a trend towards a higher prediction accuracy and better refractive outcomes using the TK. In a study conducted by Fabian et al., they have compared the prediction accuracy of the total keratometry compared to standard K using different IOL power formulae. So as we see that Barrett TK has performed much better than all of the other counterparts by having a significant chunk of the population within 0.5 diopters and within 0.75 diopters. Similarly, the cylindrical correction as well is significantly better with the Barrett TK using the TK values. In post-refractive surgery eyes, when using the Barrett True TK formula, which was specifically designed for TK, it outperformed any other non-history formula in the post-myopic LASIK eyes. In a study which is conducted by Lawless et al., they have compared various formulae and various K values, of which the Barrett True TK came out significantly on top with a higher significant proportion of people within the plus minus 0.5 and plus minus 0.75 diopter range. So that was the end of my presentation, sir.
So, Pranav, I wanted to ask you, very nicely done, that it's a good idea if we would compare the Barrett's True K TK with the Barrett's True K, because Barrett's True K will be using only the
Normal
anterior
K.
corneal measurements, whereas Barrett's True K TK will be using the uh, anterior and posterior. So for our post-refractive surgery eyes, in fact, what we can do is we can do a retrospective study of say 10-15 patients of hyperopic, myopic, and RK eyes, LASIK eyes, and we can see whether the predictability of the Barrett's True K TK was better than the Barrett's True K by itself.
Got it, sir.
So we can do a retrospective because we have good number of post-refractive surgery eyes over the last few months.
Yes, sir.
And we
Sir,
also have
will
the
we
refractive
include
outcomes.
toric, non-toric in this, sir?
So I think we'll ignore the toric part because for now, because I don't think there is a Barrett's 2K TK toric.
No, sir, there is not.
So we won't include those.
Yes, sir.
Yeah. Although I think online there is a Barrett's 2K TK toric also, but it's not there on the 700. But you can check online.
Okay, sir.
But I think we did cover a lot of very important aspects today. And thank you for working hard to make it meaningful and fruitful because, a lot goes into, preparing these classes and, I think better understanding for all of us where to use which K readings and also the EKR report, EKR 65, and how it is centered and the total corneal powers because these are very, very important concepts to understand. And here, if anybody has any questions, it'll be nice.
So I wanted to point out that we had also used the similar things for the ALKIs as well. I think we had done four of them as yet. And like till now, we were using only the EKR 65, that one screen that initially we were using. So I think we can
Yes,
put that across to that other pupil centric thing also, the other second screen that Pranav has showed, so that
the
we can
total
actually
corneal
kind
power. In
of.
fact, for today's patient that we did use this screen only. And
Okay.
because I pointed out, because the EKR 65 was showing haywire values. So I told
Yes, sir.
Pranav that, see, in fact, Antiran was also doing the same thing. So when
Yes,
we
sir.
analyzed it, I told Pranav that, see, this is picking up the case basically from a decentered area over the patch graft, which is actually opaque.
Yes, sir.
And there's no
Yes, sir.
point because it was
Hmm.
detecting the pupil wrongly, and so was the anterior, and also was picking up the pupil incorrectly.
Yes, sir.
So then we actually changed over to this total corneal measurements, and then we use that.
Yes, sir.
So you're right. I mean, that's how we learn, and where to
Yes,
use
sir.
which
So
one. That's the important
maybe
thing.
we can open because the pentacams had already been done for those patients in the EKR.
Yeah,
So
exactly. We
probably
can
I'll
do a
just.
retrospective study,
Yes,
and you can
yes,
actually go back and see 10, 15, 20 patients and see what was working better.
yes, yes, sir.
It'll
Because
be
our
useful.
results were quite okay, but obviously for the better results, this one's better. But once we were getting okay results with them also, so we have to see the accuracy of both in that case, I feel.
Sir, I had one doubt. For today's class, when I was going through a lot of examples, I mean, I wanted to include an example of a post-RK patient in which we have done toric IOL and how the EKR
Ah,
65 values corresponded with the pre-op and the post-op refraction. But the problem
ah.
which I encountered heavily in most of the patients was that the pre-op autoref values varied at each visit so significantly that I was not able to get a good baseline to compare it with and also get a good baseline for the post-op values. So how
So
do we
that you won't be
determine?
able to do the pre-op RK patients, the auto values will be haywire anyway, so we can't trust them at all.
So then, sir, if we wanted to see that we have based our toric calculations on IOL master and Lenstar using the normal anterior SIMK values, and had we used the EKR 65 values, what we would have gotten, and versus what we have actually gotten, and would EKR 65 values have been much better to use? How do we like put that through in points? Like
So
how do
autoref
I
is
go
not a
through?
good measure. See, the preoperative autoref is also getting impacted not just by RK and the astigmatism and everything, but also by the cataract. See, so it won't be accurate at all. And it's only in the post-operative period where, if at all, the autorev may be accurate to some extent, but maybe a retinoscopy might be the best way to assess that. And that's how I would think that we would want to assess post-op. The pre-op, I don't think has any value whatsoever.
Okay, sir. Got it, sir.
Chalo, I think we've had a long class and it's been really nice, but very well kind of presented. And thank you for doing that. And I think we all learned quite a bit today. do archive this on YouTube so that if anyone of us wants to go back and see it again, then we can do that and share the link on the doctors group once it has been archived there, Pranav.
Yes, sir.
Also for the previous classes that we've done so far, like we can have the YouTube links posted on the Drishti Docs group for anybody who wants to go back and see those or listen to them. And keep them private so that only those people with the link can see it, not anybody else.
Yes, sir. Yes, sir.
Okay, na?
Yes.
Chalo ji. So thank you everyone,
Thank you,
and
sir.
have a sorry for
Sorry,
delaying
sir,
the
but
class
just a
today.
reminder for the Dr. Sheetal Brar case
Yeah,
report
I've
thing you
already
have to.
messaged her. Yeah,
Okay,
I'll
sure.
finish it off. I'm waiting for her reply actually. Otherwise,
Yes.
I'll call her.
Okay, sir.
Okay.
Yes, sir, sure.
Thank you,
Okay. Thank
Amrita.
you so
Thank
much,
you.
sir. Good
Good
night,
night.
sir.
Good
Thanks.
night.
Good
Good
night.
night.
Thank you. Good night.